Hi everybody, my name is Taylor Armstrong, and today I am going to be presenting about body dysmorphic disorder. So just a quick overview of our agenda. Today we're going to review the major characteristics of body dysmorphic disorder, etiology, so the causes, and implications for treatment. So what is body dysmorphic disorder? BDD is a DSM-5 disorder that is characterized by distressing or impairing preoccupation with slight or imagined defects in one's physical appearance. And the key here is slight or imagined. It's important to remember that these are not the ordinary concerns that most of us have about our appearance. They are far more extreme, leading in many cases to complete preoccupation and significant emotional pain. So let's go ahead and review the DSM-5 criteria for body dysmorphic disorder, or BDD. So A is a preoccupation with one or more perceived defects or flaws in physical appearance that are not observable or appear slight to others. And next, criteria B. At some point during the course of the disorder, the individual has performed repetitive behaviors, such as mirror checking, excessive grooming, skin picking, reassurance seeking, or mental acts, comparing his or her appearance with that of others in response to the appearance concerns. Criterion C. The preoccupation causes clinically significant distress or impairment in the social, occupational, or other areas of functioning. Last criterion D. The appearance preoccupation is not better explained by concerns with body fat or weight in an individual whose symptoms meet diagnostic criteria for an eating disorder. So what are some major characteristics and symptoms of BDD? So people with BDD are obsessed with some perceived or imaginary flaw or flaws in their appearance to the point where they firmly believe they are disfigured or ugly. Most people with BDD have these compulsive checking behaviors, like I mentioned in the last slide. Another common symptom of BDD is avoidance of usual activities, because the fear that other people will see this imaginary defect and just be absolutely repulsed at them. So really this can lead to a lot of social isolation. It's important to remember that others do not see the perceived defect, or they see it within a normal range. Yeah, as a result of this, these people may become isolated and never go out. Some more major characteristics of BDD. So a common feature is that people with BDD frequently seek out reassurance from friends and family about their defects. But the reassurance only offers temporary relief and isn't ever really a lasting cure, if you will. People with BDD frequently engage in excessive grooming, often trying to camouflage their perceived flaw through their hairstyle, makeup, or clothing. One challenging aspect of diagnosing BDD is that a large proportion of patients with BDD will present to non-psychiatric specialties and may not themselves identify that they're suffering from a mental disorder. And so this is interesting. So perhaps these individuals show up in their doctor's office or cosmetic surgeon's office, just really convinced that they have something wrong with them. And oftentimes these individuals get referred to us as psychotherapists to help them work through this BDD. So On average, people suffering from BDD in a psychiatric service will spend 3 to 8 hours preoccupied with their physical appearance, though about 25% will spend more than 8 hours a day. These preoccupations are intrusive, unwanted, and associated with distressing emotions such as shame, disgust, anxiety, and sadness. Often insight regarding the appearance beliefs is poor. So these beliefs can really be of a delusional intensity. Studies have found that the current delusional beliefs in BDD range from 32 to 38%. And also the presence of delusional beliefs is linked to increased severity of BDD symptoms. Body dysmorphic disorder is associated with markedly poor quality of life, high levels of perceived stress, and strikingly high risk for suicidal ideation, suicide attempts, and completed suicide. Age of onset most often begins in adolescence, a period in development of accelerated changes in hormones and physical appearance. These factors may potentially contribute to or trigger the development of BDD, but these have yet to be directly studied. BDD is not a rare disorder. It affects an estimated 2 to 3% of the general population, and up to 8% of people with depression. And that estimated 2 to 3%, that's about 1 in 50 people in the United States, I believe. Prevalence seems to be equal in men and women, though they tend to focus on different body parts. And to say a little bit more about that, men with BDD tend to focus more on their genitals, body build, and balding. Women with BDD focus more on their skin, stomach, breasts, butt, hips, and legs. People with BDD very commonly also have a depressive diagnosis, with some estimates being over 50%. And along with this depression, this can lead to suicide attempts and/or death. So it's a very serious psychiatric disorder. Rates of comorbid social phobia and obsessive compulsive disorder are also quite substantial. Many psychiatric illnesses have been reported to co-occur with BDD. The most common being major depressive disorder, social phobia, obsessive compulsive disorder, and substance misuse disorders. So what is the etiology of BDD, and what causes it? So taking a biopsychosocial approach, one study found that over-concern with a perceived or slight defect in a physical appearance, so BDD, is a moderately heritable trait, meaning you could get this from your genetics. It could be passed down to you. Secondly, BDD seems to occur in a sociocultural context that places great value on attractiveness and beauty, and people who develop BDD often hold attractiveness as their primary value. And there's a possibility this was reinforced during childhood. Appearance was more reinforced than their behavior. And it's possible they were once teased or criticized for their appearance, which really caused this conditioning of disgust, shame, and anxiety to their own image. One study of individuals with BDD found that 56 to 68% reported a history of emotional neglect or emotional abuse, and approximately 30% reported a history of physical or sexual abuse or physical neglect. So what's the neurobiology of BDD? Clinical observation suggests that individuals with BDD may have perceptual distortions as they perceive defects in their appearance that are not observable or appear minor to others. These observations suggest possible disturbances in visual perception and/or visuospatial processing. So, treatment of BDD. Treatments effective for treating OCD are effective treatments for treating BDD. There is a form of CBT emphasizing exposure and response prevention. It's really getting the client to focus on identifying and changing distorted perceptions of their body during exposure to anxiety-provoking situations. For example, wearing something that highlights the defect, and on prevention of the checking responses that follow. CBT for BDD aims to help patients build an alternative understanding of their difficulties, reduce self-focused attention and ruminating, and self-defeating coping strategies. Patients are guided through graded exposure or behavioral experiments to test out their fears. As insight regarding the appearance beliefs is often poor, and patients may be very ambivalent about psychological treatment, motivational interviewing techniques will often need to be applied at later stages of therapy also. So, some evidence indicates antidepressant medicines from the SRI category often produce moderate improvement in patients with BDD, but many are not helped or only show modest improvement. It seems higher doses of SSRIs are needed to treat BDD relative to OCD. SRI medication refers to all of the selective SSRI class of antidepressants, so fluoxetine, sertraline, paroxetine, citalopram, etc., and one antidepressant from the tricycle class, clomipramine, which is a potent SRI. The treatment of BDD. CBT is considered the most effective psychological treatment for BDD. It's based on the core principle that maladaptive beliefs and interpretations, as well as problematic behaviors like social avoidance and rituals, are thought to play a key role in the development and maintenance of BDD. So what are some barriers to treatment? Feelings of shame are strongly associated with BDD, and the stigma associated with suffering from a mental illness might deter individuals from disclosing their concerns. Next, psychological or psychiatric treatments are often perceived by people to be ineffective. Therefore, many of them might choose cosmetic treatments over psychological interventions. However, these cosmetic procedures are generally associated with poor outcomes for individuals with BDD and do not reduce BDD symptomology. Lastly, logistical and financial barriers, especially concerns about insurance coverage and a lack of knowledge about appropriately trained treatment providers, might prevent individuals from help seeking. Some factors influencing the development of BDD. Like I mentioned earlier, teasing or criticism related to physical stigma such as acne, may have a long-term impact on an individual, negatively affecting one's thoughts and emotions. Cultural. Western culture increasingly focused on looks as everything, with billions of dollars being spent on appearance. Environmental. There's preliminary evidence that sexual, emotional, and physical abuse and neglect in childhood may be associated with BDD. Perhaps an environmental example is, your parents or guardians were more focused on your appearance rather than your behavior. So it became very appearance-oriented. All right, and there are my references. And thank you guys so much. I hope you enjoyed and learned something.